So S1 coincide with the carotid upstroke. So the S1 is comprises of M1 and T1, and what are the factors that the S1 will determine means the S1 will determine structural integrity of the valve, position of the valve at the onset of the ventricular systole. All these will be determined by the S1, and your S1 is inversely proportional to that of the PR interval. That is, from atria to the ventricle, the impulse conduction is there. No, whenever the atria to ventricular impulse conduction is decreasing, the S1 will be, the intensity of S1 will be louder. Like your short PR interval, your intensity of S1 is increased. In which conditions that this will happen means in your WPW syndrome and Levine-P-Ganong syndrome. All these syndrome will have your loud S1. Whereas in the long PR interval, in which conditions this long PR interval do happen in aging and degeneration and congenital conditions, where you will have your long PR interval. In these cases, you will have your S1, which is soft S1, and increased ionotropic activity of heart is directly proportional to S1. So whenever this when what in what conditions the inotropic activity of heart will increase, such in pressure overload status. In every pressure overload status of a particular chamber, that time the intensity of the S1 will be increasing. So that we will be going to see. And let us discuss about loud S1 conditions and soft S1 conditions. But before going into the loud and soft S1 conditions, we have to know about something, that when do we call S1 as really loud. So yes, the S1 is really loud when the intensity of the sound of S1 is at mitral area the intensity of the S1 at the mitral area is same to that of the aortic and pulmonary area. On such condition only we will call the S1 as a loud S1. So such same conditions of loud S1, in what conditions you would expect means, as I said, whenever the isovolumetric contraction of the heart is increasing, that time the S1 will be increasing. So at what conditions do we expect that means in your pressure overload status, like your MS and your AS. So in your MS and AS, what happens is, there will be in your mild moderate MS. What happens in mild moderate MS? Basically, you need to know about the valvular movement of the mitral valve. So basically, at your systole, what happens is, the MS will cover the 1/3 of the movement. This is an anomaly. You should this is a general thing you need to remember. If you want to remember this condition, then you need to see the echocardiography video of the mitral valve movement. Your mitral valve movement will not be completely 90 degrees of closure from the edge of the valve at the time of diastole till the systole. The movement will not be complete course in the cardiac cycle. At mid phase of cardiac cycle, it will cover half of the distance. Mitral valve will cover half of the distance normally, and at the time of diastole, at the time of the ventricular filling, after the ventricular has been filled, the mitral valve will close nearly half of the distance only at a normal condition. But in your mitral valve stenosis, what happens is, the mitral valve will cover the full course of distance at a particular time of the systole. So you need to see echocardiography video to understand this concept. Okay, so just I will give a key to the echocardiography video of the mitral valve movement, so that you could understand this condition. And your AS, your aortic stenosis, where you will have your loud T1. Your loud T1 will have your aortic stenosis. And short PR interval, as I said, the conditions, and hyperdynamic circulation, where the heart rate will be more and more contractions are seen. And thinner people, often you will expect the loud S1. What are the hyperdynamic circulations you would know? That is your fever, sepsis, pregnancy, thyrotoxicosis, all those conditions are hyperdynamic circulation. What are your soft S1 conditions? Your soft S1 conditions include your MR and TR. So why does MR and TR will have the soft S1? So basically what is S1? S1 is the closure of M1 and T1. Yes. So what happens in MR and TR? The walls are not closing properly. So when the walls are not closing properly, then how would you expect to have S1 normal S1? No. So that is the condition here. And in MS, I have said already that in MS I would expect a loud S1. Then why I am saying the severe MS or a calcified valve MS will show a soft S1? Yes, that is very very important to know that in mitral valve severe MS what happens is there will be calcification of the mitral valve. Whenever the calcification of mitral valve is present, then the calcification of MS will lead to the tapping sound of the valve. Whenever they hit together, the non-playable valve won't create sound, whereas the playable valve only creates the sound. So that concept you need to understand. And in AR the soft S1 will be expecting. So what happens in AR? Basically at the full diastole, full systole of the ventricle, the blood does not completely pumped into the aorta. Some of the blood is pumped back to the ventricle itself. So at every phase of time in the aorta, in the ventricle, there will be some amount of blood. So what happens? There will be a less pressure gradient between the left atria and the left ventricle. So whenever there is a lesser pressure gradient between the left atria and the left ventricle, that will cause the S1 to be non-variable. That is your soft S1. And in bradycardia, where the heart sound itself very slow, so that you will expect a low intensity S1. And your long PR interval, the reason already I have said, so refer to the if you can't understand, you just rewind it. And in heart block, you would expect a PR interval variation. In every heart block you would expect the soft S1. And talking about your soft S1 conditions, another more, that is your effusion and your emphysema and your obese conditions, where you would expect a soft S1. What are variable S1 conditions? Your variable S1 conditions include your AF, your VT, ventricular tachycardia, your atrial fibrillation, your complete heart block, where you would expect a variable S1. And your split in S1. Your split in S1 can be expected in the complete right bundle branch block, your ASD and Epstein's anomaly. So what is Epstein's anomaly? Your Epstein's anomaly is nothing but normally forming a tricuspid valve or placed lower to that of the anatomically normally heart. So your anatomically normally heart will have a tricuspid valve at a normal position. Whereas this Epstein's anomaly, what happening is the tricuspid valve is lowerly placed. So what happened? Yes, the normal electrical conduction of the left side, the normal electrical conduction will be reaching the tricuspid valve later. So what happens? Your M1T1 gap will be increasing. Your M1T1 gap is increasing, then the S1 will be splitting now. That is the condition here. Epstein's anomaly will have a split S1. Why it is having split S1? Because the tricuspid valve in the Epstein's anomaly is placed lower, so that you would expect a split in S1, and you would expect a split in the S1. And I am saying now itself, you remember, there will be a split in S2 too. There will be a split in S1 and S2 too, because of the electrical impulses that is coming out. And your opening snap will also be splitting. What is opening snap? Yes, your opening snap is nothing but your closure of the, yes, your closure of the aortic and your opening of the aortic and pulmonary valve is your opening snap. Why does it varies? Yes, as I said, the tricuspid valve is placed lower, so that the filling of the ventricles will be low, filling of the right ventricle is be delaying. So the closure of the tricuspid valve is delaying, so the overall cardiac cycle over the right side is delaying, so that your pulmonary valve will close later, your pulmonary valve will also open later. The conditions relating to the right side will be delaying to that of the left side. So that is your problem in your Epstein's anomaly. So that you would expect a split in the S1, split in the S2, split in the opening snap, and you would get a pulmonary ejection click. What is pulmonary ejection click? Your pulmonary ejection click is nothing but that is a pulmonary ejection click. What is click? Click is your opening of the opening of the tricuspid valve. So opening of the tricuspid valve, why does it happen? Yes, it is the delay in the opening of the tricuspid valve happens, so that the filling, the whatever blood that has been filling in the right atria from a normal patient to that of the Epstein's anomaly is quite longer in duration. So that the amount of blood filled in this Epstein's anomaly in the right atria is more, so that you would expect there is pulmonary ejection click and your left ventricle pacing. So what is left ventricle pacing? Basically you would use a pacemaker in a left ventricle in a heart failure patient, so that you would expect a split in the wide split in the S1, and there is a reverse split. What is reverse split? Yes, we can expect a condition, that is your T1 M1. Where does it occur? Yes, in your mitral stenosis. What happens in severe mitral stenosis? Yes, in your severe mitral stenosis, what happens is the valve does not open very longer, so that the amount of blood in the left atria is somewhat more, and the blood continues to descend at a high pressure. So what happens here? The right side atria and ventricle are normal, and it closes at appropriate time, whereas this left atria will still having some more blood to descend. So more amount of blood in the left atria will create a pressure that will overwhelm the valve to close later. So the valve will close later in severe MS compared to that of the tricuspid valve. So this is the pathology that you would expect in the reverse split. And incomplete left bundle branch block. In complete left bundle branch block, the electrical impulses that will pass to that of the left side is completely blocked. So the right side impulses are faster than the left side impulse. And your ectopics are the abnormal foci of the abnormal foci that would generate the electrical impulse. Yes, if it present in the left side, then it would cause a left. If it is the ectopics are present at the right side, then you would expect a right-sided cardiac cycle to be more. And your RV pacing, where the RV pacing is often used in the conditions that are right ventricular failure. The more details of RV pacing will be discussed in the next video. So this is about your reverse split, and talking about S1 sounds. S1 sounds discussion is over. Thank you.